So I think we have 4 minutes before we had Dr. Suchit's talk. I don't see Suchit is here as yet, and unfortunately, I don't see my co-chairman, Dr. Parida, also. I can see Arindam, who is around also. So can we just have, from the organizers, find out if Suchit is logging in, or till the time that he logs in? I think what we can do, if Arindam is around also, is that we can have, we don't have any questions in the chat box, but we can have some questions to Arithro and to Dr. Roy. So Arithro, to start with, if I can just ask you, you have talked about these other drugs that you talked about, vericiguat, and you've talked about the lanoxin, and you've talked about isolazine, and you've talked about ivabradine. Now let's look at this clinical scenario in this gentleman who has a blood pressure of 100 by 60, and who has a creatinine which is elevated and a pulse rate that is 80. Which would your choice be first to start with this group of drugs, especially for this patient who has had recurrent heart failure hospitalizations?
So first of all, sir, the pulse rate is 80. So obviously, if I think that the patient is already getting maximal tolerated beta blocker, since we have mentioned that patient is already on four foundational drugs, then there is definitely a scope of adding ivabradine to reduce the heart rate to at least 60 per minute. Why not? So I think ivabradine will be the first choice in this patient, sir.
And then what about the other drug? I mean, then I think vericiguat should probably come in higher up also, because this
Absolutely.
is worsening heart failure. This patient has had, and especially with the creatinine, with the other drugs like lanoxin, we'd be again worried about the creatinine values. And with isolazine, I think with this blood pressure, we'll not be very stable and will not be very comfortable. But I think vericiguat is good in that sense, because blood pressure control, I mean, loss of drop in blood pressure as well as the renal functions usually are not so much worrying for us when you start the vericiguat. I think that's one drug that probably will come higher up in the list of medications. And besides that, I think we've also talked about iron therapy, which again is, I think, very, very common. And I think all our patients probably get their shot of FCM once they're in the hospital with heart failure. The other thing I also think about is the obstructive sleep apnea. Well, not for this patient, we don't know his weight, but I think that's again one more thing that contributes to heart failure. And we find a lot of patients who have that was previously undiagnosed. Arindam, your thoughts there, and Arito, you can also chip in with your thoughts.
Yeah, obstructive sleep apnea, I feel, is very important, because probably the disease was very prevalent. We are not evaluating the patients. Now we are evaluating. So at least in my practice, many patients are detected with very advanced obstructive sleep apnea, and they do respond well with therapy, lifestyle measures, as well as some form of CPAP and all. So Dr. Arito nicely summarized the current existing medical therapy. Now, what do you feel? What else is there in pipeline? Because heart failure, as we all discuss all the forum, that whatever new medicine comes, still the mortality is very significant mortality, even after utilizing all the current modality of therapy or the devices and all. Still, people are dying. So that really shows some interestingly in that trial, used regarding this omecaptive mecarbil or any other new molecule therapy.
So Arindam, I think your voice is a little unstable. I think we've not missed most of the talk that what you spoke. Can you just repeat what you were trying to ask? I think he's got logged off also. Dr. Rathod, I think whilst and Arithro also seems to have left. So Dr. Rathod, I think whilst we're waiting for the Arindam is back again. Arindam, you can just put your thoughts again, please.
I just new molecule there in pipeline, and if you can briefly talk about the molecule mecarbil, which was in galactic heart failure trial, whether it's a good molecule to bank on, because it is not yet available in Indian market.
I think, sorry, I'm just chipping in. I think Arindam is asking about the drug, the domecaptive mecarbil, I think that was withdrawn. No further investigation is going to be done on that because of some problems with it. So it's no more going to be marketed.
Yeah, it very interestingly increased the troponin I level in the trial arms. So I'm not sure why it happened. So any further?
Yeah, so I think, Dr. Rathore, again, coming to your discussion on the scope of CRT and CRT-D, I think one common thing that happens with most of us is that when we have these patients with ischemic LV dysfunction, sometimes it does become difficult to just talk to patients about a primary prevention where we put in a CRT-D. And most of us do try to look for other sort of high-risk markers. So in your clinical practice in a patient like this, how commonly would you pursue more with, say, a Holter monitoring or an extended loop monitoring, or you'd want to do, say, a cardiac MRI to document the scar burden? I mean, just looking proactively, would you do something beyond the data that we have now? Or I think, do you think you're happy with this data to say that you would still, based on the guidelines, look at a CRT-D in this group of patients rather than a CRT-P?
No, yeah, in patients who are ischemic etiology, if you see on the baseline 12 ECG, if you are seeing the ventricular complex, VPC is more frequent ventricular complex. On if in the Holter monitorings, if you see the VPC load is more than 10%. And if
I think we are losing him again.
Any role of MRI evaluation of myocardium before going for CRT-P or CRT-D decision? Dr. Khan, your comment?
Yeah, I think the network is...
attendees are there, but our group is much smaller. I am seeing the attendee group is very large.
Yeah, somehow I think the network is playing up with most of our speakers. So I think the problem is that, yes, we do talk about primary prevention. Rathore is back. Dr. Rathore, I think what you are asking is that what is your sort of workup strategy in terms of a Holter monitoring or a cardiac MRI to document the scar burden? I think you're muted. You need to unmute yourself, please. You need to unmute yourself, Dr. Ryan.
So in Holter monitoring, if we can assess the VPC load and if there is non-sustained VT on the Holter monitorings, then definitely these are the candidates for ICD. And on MRI, if you can assess if we can see the late gadolinium enhancement, that is very one suggestive for arrhythmia. So if you can see the late gadolinium enhancement on MRI or the scar on the MRI, these are the things which are favor of defibrillator therapy in a ischemic etiology.
So coming back to Dr. Prakash's question, I think when it comes to an ischemic LV dysfunction, I mean, for this patient, for example, on an echo, we have we've already talked about an anterior wall motion abnormality. Probably there's a scar already. Though on ECG, we may not be able to see the QAs that we see normally in a patient who does not have a left bundle branch block. But in this patient, because there's been an anterior wall occlusion of the LAD and there is an akinetic anterior wall, probably doing a MRI may not be of benefit. But it's mostly for the non-ischemic idiopathic cardiomyopathies where you don't have a coronary disease, where I think the MRI becomes that much more important because the burden of scar. So there is data to suggest that probably if you have more than a 15% scar in a patient with a non-ischemic cardiomyopathy, probably the fact that you would probably think in terms of a CRT-D over a CRT-P, because then you have a substrate for a high-risk arrhythmias. Okay, I can see Suchit here, so I think we can go back to his talk and then probably come back for the discussion thereafter, if it's okay with the organizers.